I'm Dr. Craig Escudé, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
The IDD Health Matters podcast is a joint production between Friends for Life and IntellectAbility. For more information, go down into the show notes and click the link where it says Learn More here.
Hello, and welcome to this episode of IDD Health Matters. Today I have with us two international guests, Professor Angela Hassiotis and Dr. Rory Sheehan. And so I'm just going to turn it over to whoever wants to go first and tell us your story, tell us what you do in this field and where you're from, of course.
Hello everyone. I'm Angela Hassiotis. I'm a professor of psychiatry of intellectual disability at University College London. And I also work in the NHS as a consultant psychiatrist for people with intellectual and developmental disabilities. My service is for people 18 years and over. And I am originally Greek, but I've been in the UK practicing and living for many years now. I'm a researcher and a clinician, as I said, and maybe we can go into the more detail as we go along.
We certainly will.
Hi, thank you everyone. Rory Sheehan. I'm a senior clinical lecturer at King's College London, and I also work as a psychiatrist in the NHS in London. My work is with people with a learning disability or who are autistic and who have offending behavior or who have found themselves in trouble with the law. And my research work in learning disability predominantly is with quite wide-ranging, really. It covers medication use for people with a learning disability, best practices, and I'm particularly interested in the use of big data sets and how we can use information from electronic health records and routinely collected sources to improve care for people with intellectual disability or who are autistic.
Thank you for those introductions. Now, just to clarify things, NHS in the UK means what?
The National Health Service, which we're very proud of.
All right. And then learning disabilities is synonymous with intellectual disabilities. Is that right?
That's right.
Okay.
Yeah, that absolutely is. And I guess, we use those interchangeably, but we are talking about the same thing.
Okay. Just wanted to make sure we are all on the same page here. So we are at the what we call the IACID conference, which is the international. Please elaborate.
Yes. So this is now an organization by researchers, clinicians, professionals, and people with lived experience. It's 60 years old this year, and it is the International Association for the Scientific Study of Intellectual and Developmental Disabilities.
And so, Angela, I had the pleasure of being in one of your workshops. Tell us what that workshop was about, if you don't mind. I think it was very fascinating.
Well, thank you so much for mentioning it and also for attending. So as part of IACID, we deliver what we call the pre-Congress workshops, and I held one on a study that I've been carrying out in the UK. Actually, it's a study that is for personalized interventions for aggressive, challenging behavior for people with intellectual developmental disabilities who live in the community. And it is a multimodal intervention which is addressing, or I hope it will, some of the gaps that we have seen in intervention delivery in the literature and in our services. So we talked about the PETAL study. This is a program of work which is funded by the National Institute for Health and Care Research in the UK. And it is a study that is conducted in 3 of the 4 UK countries, Scotland, Northern Ireland, and England. So we have co-produced or co-designed the intervention, which has 7 modules which are delivered in about 14 weeks or so. by NHS professionals, and we are now in the phase of testing it.
So you say they're delivered by professionals. Who is the audience?
The people who, I'm sorry, can I just check the audience as in?
Who is the training for?
So the training is with professionals from any health background or even social work. However, social work in the UK, or our social workers, are only doing commissioning of services, so they don't necessarily go into the delivery of therapy. So this is a split that happened some years ago, and this is how services work. So say, for example, a social worker will recognize or assess the need, there is a need for a person to receive, say, psychosocial therapy, and then they will make a referral to health professionals who work within the intellectual disability services, and we then decide how we're going to go about this. So the people then who may take on the delivery, so they will be trained and so on, will be people who have had or have a background in occupational therapy or in nursing, psychology, even actually psychiatrists. So a number of psychiatric residents, for instance, have been trained and have delivered this intervention. So pretty much anyone could be trained and deliver it in our services.
Excellent. So, Rory, tell us about, you mentioned big data, right? Data sets.
Yes.
Tell us more about that. What are you looking at? What are those related to?
Yes, so it's a good question. And of course, big data is really increasing in prominence in research work over the past few years. So the data sets that we have used are national primary care data sets in the UK. And we are lucky that, as Angela mentioned, we have the National Health Service, the state provider of healthcare in the UK. And the vast majority of people living in England do have an NHS GP, a general practitioner, a primary care physician. So we do have pretty good data actually on a population level of people accessing primary care. And we've used that data set for a number of studies actually to look at the primary health care that people with a learning disability or autistic people receive. We also, at my institution, which is King's College London, we have access to a secondary care health data set. And this is people who are accessing specialist mental health services across South London. And we call this data set the CHRIS data set. And that enables us to look at people who are either accessing outpatient care in with psychiatrists or any member of the multidisciplinary team, and also people who are admitted to a psychiatric hospital. So we look at those, and then there are a number of other data sets that are existing, like mortality data sets in the UK, or data sets that look at admissions to general hospitals, and we can try and link those data together so we get more of a fuller picture really of the care pathways that people are accessing, and the number of contacts, etc., and how they fare in that.
Do you feel like in the UK that the diagnosis of a learning disability is pretty accurately reflected in those data sets? Like, do you feel like you're capturing most people who do have a learning disability?
Also a good question. I mean, I suppose the different data sets probably are different in that respect. So probably not. There are probably a number of people who...
That's the case everywhere.
Yeah, who do have a learning disability or intellectual disability who don't make it into that research really. For that reason, they're not recorded as having the intellectual disability. But still, I think we do have pretty good numbers. We can see from the data that we get that we're able to gather sort of much larger cohorts using these data sets than we would doing sort of more traditional research where we were looking to recruit people for a particular study. So there are advantages for sure. There are also some disadvantages to this methodology.
So I'm going to come back to you in a second to ask you what are some of your most interesting findings. But I'm going to go back to Angela and ask about, all right, you said you're in the testing process of this program, right? Do you have any preliminary results? How is it looking so far?
It's very early days. So at the moment we have something like, so we did the modeling first of all. So we developed the intervention and then we did a very small study to see actually how it goes in practice. You know, can people attend the sessions? Can it be delivered in the way that we would like it to be delivered? By the way, this is a manualized intervention. So there is a manual for the therapist in terms of what they're supposed to do, the steps they have to follow. We've heard from people with lived experience about certain elements that they wanted to see included in the therapy. So, for example, one of the things that we're very keen on is that we would say something around communication, and that we would say something about, you know, who is the person that we want to deliver the intervention to? Because, of course, someone with who displays aggressive, challenging behavior can be stigmatized in a number of ways. And that was one of the concerns that the people with lived experience who advised us were really very keen that we should be careful about how we put it forward and how we explain it to practitioners. We have to take into consideration as well that people might have had all sorts of traumatic or otherwise kind of contact with services. So all of those things kind of being taken into account. But what we know from the modeling is that people have been engaged. We have responses like we've never seen them being so quiet in a room or wanting to do a particular task, being engaged in the task. Even people who have more severe level of disability. And generally the therapists or the professionals who volunteer to deliver it were actually very pleased with the training they've received. Of course, you know, with anything, we had to revise certain aspects, how we actually go about the logistics of delivering the therapy, but these are not unknown facts, and we were expecting that we would have to do some refining of the intervention. So at the moment, we've got just over 50 individuals who have consented to be in the study, and for whom we've got baseline information. And we actually, the trial hopes to recruit 410 individuals. So that's actually quite a big ask in terms of participant-facing research. And also this is a group of individuals who, for all sorts of different reasons, there may be gatekeeping, etc. So there are some challenges that we are working hard to overcome. So that's where we are.
There's always challenges. I love the fact that you have included people with lived experience, and we're hearing so much more about that and the importance of that in research. In fact, that was the opening session of this conference, where partnerships between researchers, academic researchers, and people with lived experience working together to, have better research or have better outcomes and develop programs that are more suited for people, which is great. So that's great to hear.
May I just say one point here about this? I was looking at the paper that we are developing at the moment about the experience of the people, who advised us, from the lived experience. And I looked at what we did before we applied or during the preparation of the submitted application, and actually what happened subsequently as well. And I have to say, I was even surprised myself in terms of, the kind of buy-in, I guess, that we had from individuals, and also the courage that took those individuals to come up with, to agree to talk to me about the study for a topic that often is something that people try to avoid talking about. But these are the people who actually have displayed aggressive, challenging behavior, have been to services, are taking psychotropic medications, and yet they were actually willing to help others. So that was one of their express motivations for taking part in research. And of course, we know that actually including those individuals, we do better research anyway. So
That's wonderful. So Rory, what are some of the big data findings that you have to share?
Yeah, so I was thinking about this as Angela was talking. I think what I'm going to talk about is a study that actually I did with Angela several years ago now, and we published in 2015. This was a study that looked at the rates of psychotropic medication prescribing for people with intellectual disability in UK using a primary care data set that I sort of mentioned earlier. I think the reason that I'm sort of talking about this now is because that study really had quite a major impact actually in our country, and maybe I can also say internationally. We've been concerned, or the community has been concerned about the use or the potential overuse of psychotropic medication for people with an intellectual disability for many years. And what we were able to do with our work is to show that actually, yes, indeed, a large proportion of people with intellectual disability were prescribed psychotropic medication, but there was also a discrepancy between the rate of prescribing and the rate of recorded mental illness. So many more people were receiving a psychotropic drug than were diagnosed with a mental illness. Now, there's a lot more nuance to that finding than the headline that I've just presented. But I suppose what this work did was really focus our minds on the need to really make sure that when we prescribe a psychotropic drug for someone with an intellectual disability, we are getting it right.
That's a great point, and it's something that is in the U.S. as well. We see more people receiving psychotropics that don't have a psychiatric diagnosis, and I tend to, think about that in a way of, one, it can be very challenging to get an accurate psychiatric diagnosis, especially in people who don't use words to communicate. And then the other part of that is it also suggests to me that we're using psychotropic medications to treat adverse behaviors, not necessarily a mental health condition. Is that something that you can relate to? Does that sound...
So absolutely, both of those things are probably, there's certainly explanations for some of the differences in rates of prescribing and diagnosis. I think on the first point about diagnosis, we would probably say that this is why we exist as specialists in the psychiatry of intellectual disability. We have received, specialist training. We work in services that deliver care for people with a learning disability or intellectual disability. And so access to sort of specially trained professionals is important in terms of getting the diagnosis right.
I know you have another point, but tell me about the training. I'm really interested in this specialist training that you have.
Yeah, okay. So maybe Angela will want to add to this in a moment, but so in the UK, we train at medical school. That's 5 or 6 years. We then, when we start our postgraduate training in psychiatry, we work across a range of psychiatric disciplines for 3 years, and that's called our core training. So that gives us a foundation really in many different sort of the subspecialties of psychiatry. It's at that point that we would decide to train and specialize in intellectual disability psychiatry, or sometimes we call that neurodevelopmental psychiatry because it encompasses other neurodevelopmental disorders too. And that's a 3-year full-time specialist training program. There's, of course, there's work in inpatient settings, in community settings. There's the opportunity there to pursue some special interests. Often it's at that point where people begin to get involved in some research work, and that's sort of how my path developed. And yes, so that's a really sort of good time to learn the basics, put them into practice, and then at the end of that 3 years, become a sort of fully fledged, independent expert in psychiatry of intellectual disability.
It's wonderful that you have that specialized training in the UK. That's something we have very little of here, if any at all, to be honest, as far as specialized IDD training. So that's great that you have that. Absolutely. So let me ask you, I'm going to pivot to a couple of things. First of all, I'm very excited to see the results of the research, because that is, as we know, a significant challenge in this field is helping people who do have challenging behaviors to be able, for us to be able to address those in an appropriate way.
Friends for Life Residential Care, specializing in support for individuals with developmental disabilities, offers services like adult day support and home health care. Emphasizing empowerment and quality of life, we live by the motto, "My ability is stronger than my disability." We are currently hiring, welcoming those passionate about making a difference. Learn more and explore career opportunities at friendsforliferc.com.
I'm Dr. Craig Escudé, President of IntellectAbility. State developmental disability agencies, managed care organizations, and providers across the United States use IntellectAbility's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support.
I would like to pick your brains and ask if there are 3 things maybe that you might say to the audience that you think are very important that can improve any aspect of health and wellness or the world in general for people with intellectual and developmental disabilities. So take it away, whoever wants to go first.
Okay. So in fact, as we were, I'm just going to continue from this last point about the training and the specialism. And I see this sometimes where I know, because I've heard a number of examples, say here in the US or other countries that I've visited, where good things are happening about people with intellectual disability, but at the end of the day, it all falls down at the point of, say, crisis, or somehow the wraparound services are not available. And it pains me to think about this and also ask the question, why not, given that there are people there who can actually do the work. So capacity building and multidisciplinary working in very sort of a way that actually people can identify that this is where they go to seek help, as opposed to going to emergency services. And this is what led me as well to this inquiry, I guess, into aggressive challenging behavior, because this is the one thing that will make, no matter the challenging behaviors, as you say, is an umbrella issue, term, but in fact, aggressive challenging behavior is the one that's going to take someone to casualty and potentially to the application of more restrictive practices. So capacity building and multidisciplinary work in healthy teams that feel happy and can work together. So I think that's really important.
It's an important addition there.
Yes. I think intervention development, whether it's an adaptation of something that we know works in other populations, take examples, see how they can be applied in our patients, for example, or actually service users in the broadest sense. Because there could be issues around well-being overall, not just mental health, but physical health as well. How can we actually prevent and promote good health to people with intellectual disabilities? And there is a lot of work, and I know that during, when we were doing the workshop, you mentioned about the fact of, medical illnesses, for example, physical ill health, etc., being a big issue. And some of it will also be because of medications that we prescribe, sometimes necessarily, that we need to help the individual and their families. And I would say that the last thing is about ensuring that at all times we look at services and we provide the kind of evidence-based care and quality improvements that will be important in terms of us being innovative, being efficient, and being effective. And safe, obviously, in our practice. So those would be my very kind of long.
Great points. And as you pass the mic, just to go back on the behaviors, I think it is so important, from a medical physician's perspective, that we rule out an underlying medical cause for adverse behaviors before we get into looking at so many of the other potential causes. And I think, when we go back to training, one thing that happens sometimes is we might refer a person with a disability to the medical doctor to be evaluated for underlying medical conditions. But if that medical physician does not have the training or the understanding or know how to communicate well with someone, they may very well miss potential medical things, which still they end up, or referred for psychiatric care, but they still may have something medical. That's a challenge, and that really it makes the case for every clinician to be trained at least in the fundamental principles of IDD healthcare. Rory, what are your 3 things?
So, I guess some of my ideas may I may be reiterating a little bit about what Angela has said, but I think from my point of view, we do need the continued commitment of the research funders to actually fund that really high quality research in this population. And that's one way which we're going to sort of get to, delivering the evidence-based care, because I think still we are maybe a little bit behind in our specialty compared with some others. So that would be one thing. Another thing is about valuing the workforce, and I mean the healthcare workforce and also the social care workforce and people who might be working with people with an intellectual disability on a day-to-day basis, and improving the sort of recruitment, but also the retention of really good quality caring staff and avoiding burnout in that. So that's my second point. And my third point, and we haven't spoken about sort of some of my clinical work today, but I do work in a forensic population, like I said, and I think it's really important not to overlook those groups, even though they may be very small in number. This is a group of people with high levels of complexity, high levels of support need, and I think it's important that they and their sort of care is recognized, and they're not overlooked in what, as we've said, can already be a marginalized group.
Well, again, those are 3 excellent points there too, and very important things for us all to keep in mind. I want to thank you very much for taking the time to talk with me today and share your perspectives. One of the things I find fascinating when I meet people from other countries in this field is we often share many of the same challenges, that's it. But there's so much collaboration that can happen as well too. So to address those, so that's one of the great things about being here. But thank you both so much for being here and for the incredible work.
And thank you so much as well.